Good afternoon. I'm Tom Shimabukuro. I'm with the Immunization Safety Office and the Vaccine Safety Team on the Vaccine Planning Unit. And this afternoon, I'm going to be giving you an overview of vaccine safety monitoring. I'll cover some of the basic issues, and then I'll touch on some of our plans and some of our systems and some of our populations. And I just want to mention that I'm presenting on behalf of our partners, FDA, DoD, Indian Health Service, and VA. Next slide. So this is a schematic that's actually posted on the CDC website, and it describes the vaccine life cycle. This describes the traditional pathway, but I think the concepts are also relevant. And safety is a priority during all phases of vaccine development, approval, and use. We start off with basic research, discovery, preclinical work, and then move to the phased clinical trials. Once the phase 3 is completed, BLA is submitted, FDA reviews, and there's an approval, and shortly thereafter, there's an ACIP review and a recommendation, and then we move into what's called phase 4. Traditionally, CDC and FDA do most of the safety monitoring. There are other federal partners that participate in this monitoring, and monitoring for COVID vaccine will be a coordinated effort by multiple federal agencies. Next slide. So I just want to mention the rationale for post-licensure, post-authorization safety monitoring. So the safety standards for vaccines are high. Vaccines are for primary prevention. They're being given to generally healthy people, at least people who do not have the disease, so it's not for treatment. And therefore, the tolerability for risk is lower than, say, for drugs or for other things that are used to treat illness. Furthermore, the pre-licensure trials are not optimal for detecting rare adverse events. The numbers enrolled are too small, even with large clinical trials like the ones for COVID, where you have 30,000 individuals. They're not optimal for monitoring vaccine safety in a real-world environment. I'll get into our safety monitoring systems and populations. Next slide. The first system I'll touch upon, I'm sure you're all familiar with, is the Vaccine Adverse Event Reporting System. This is our national spontaneous reporting system that's co-managed by CDC and the FDA. Next slide. So VAERS essentially has the entire U.S. population under as a covered population, all 320 million or so U.S. residents. This includes individuals of all ages, races, from all states, territories, healthy people, and those with comorbidities. In recent years, VAERS has received around 60,000 reports per year with a small number of foreign reports, most U.S. reports, and that averages out to about 1,000 reports per week. Next slide. So specifically focusing on older adults, I want to talk about some of the active surveillance systems in the U.S. government's arsenal. I'll start off with the FDA's Centers for Medicaid and Medicare Services data monitoring. This data monitoring system includes 55 to 60 million persons 65 and older, and this is about 92% of the U.S. older adults. The CDC's Vaccine Safety Data Link is a collaboration between 8 integrated healthcare systems, and this has data on about 1.8 million persons 65 years and older per year. And then the VA Data Warehouse and Electronic Health Record has about 1.56 million persons 65 years and older who are typically vaccinated for flu, and we anticipate would be a priority group for the VA. So these are EHR-based or claims-based or encounter-based systems, which we do active surveillance. So we have complete or near complete information, depending on the system, on a population. Therefore, we can calculate rates and assess risk. Next slide. Moving into the age group of adults and children, and I'm just to reinforce, CDC's Vaccine Safety Data Link has 8 million persons in the age of 19 to 64 years old and 2.3 million persons under 18 years old. And again, we routinely conduct active surveillance in the Vaccine Safety Data Link each season for flu, and when new vaccines are recommended, licensed, and recommended for use. Next slide. So I want to touch on a couple of FDA's systems that cover adults and children. First is FDA's Biologics Effectiveness and Safety System, or BEST. That has data from claims, EHR systems, and the FDA's Post-Licensure Rapid Immunization Safety Monitoring Program, or PRISM. That's part of the FDA Sentinel program, and that has EHR data from large health insurers with claims data and access to medical charts on about 100 million persons. Next slide. Some of the populations of our partners, our federal partners. The Department of Defense does VAERS monitoring in collaboration with CDC through a VAERS data sharing agreement. There's roughly 1.4 million active duty and 860,000 reserves, the majority of which are less than 30 years old. But this also includes dependents and beneficiaries if seen in DoD healthcare facilities. DoD also has the capability or the capacity to do active surveillance. And for COVID, the DoD Immunization Healthcare Division plans to collaborate with the Armed Forces Health Surveillance Division to monitor safety in DoD EHR systems, and is mainly using the Defense Medical Surveillance System and the DoD Personnel and Readiness COVID Registry. Next slide. Lastly, I want to mention a new collaboration between CDC and the Indian Health Service. We're currently entering into a VAERS data monitoring collaboration through a VAERS data sharing agreement. And the IHS population is mainly American Indian and Alaska Native patients seen in IHS and tribal healthcare facilities. We are working with IHS to identify reports in their patient population for individuals vaccinated in their facilities, and the analysis for the IHS data will be conducted by the National Pharmacy and Therapeutics Committee and the IHS Division of Epidemiology. Next slide.
Today I'm going to talk about enhanced safety monitoring for COVID-19 vaccines and early phase vaccination. Next slide. So I'm going to move on to our enhanced monitoring programs to meet the challenge of COVID-19. Next slide. So the first program I'm going to talk about is called the Vaccine Safety Assessment for Essential Workers. The acronym for that is VSAFE. And VSAFE is a smartphone-based text-to-web survey and email-to-web survey active surveillance program for early recipients. It uses contact information, so phone numbers, from the registration process for COVID vaccination of essential workers, which could be up to 20 million people during the first few months of a vaccination program. We plan to conduct health checks on vaccine recipients via text messages and email. These will be daily during the first week post-vaccination and weekly thereafter for 6 weeks post-vaccination. We also will conduct active telephone follow-up with persons reporting a clinically important adverse event during any VSAFE health check. And these health checks are basically text messages that we send out to the vaccinated individual, and the person can either respond via text or can click on a link to go to a web survey, or in cases where we don't have phone numbers, we can do this by email. And when we do conduct this active telephone follow-up, a VAERS report will be taken if appropriate. Next slide. So this is a fairly high-level overview of the information flow. So, I mean, at the CDC level, we will have access to contact information for these registered individuals. And upon notification that an individual has been vaccinated, we will begin the text messaging process that I just described on the previous slide, going out to the healthcare worker or essential worker or other vaccinated individual. You see the two-way arrow there, meaning there's bidirectional communication, us reaching out to the vaccinated individual and them sending information back to us via text or web survey or the web survey process. And again, these will be daily for the first week of post-vaccination and then weekly thereafter out to 6 weeks. So based on the responses that we get back from the vaccinated individual, if any clinically important adverse event is reported by the vaccinated person, we will then transmit information to a call center. This is the VAERS call center, the existing call center, to follow up via phone with this individual and complete a VAERS report if appropriate. And then per usual, those VAERS reports will get to CDC and FDA. Next slide. So this is just a text version of the script. The actual web survey is formatted for the web and looks much different than this. But as you can see, this is a typical text that a person would get scripts during the first week where they're getting daily text messages. And it's the first part of this is just asking about local and systemic reactions. I would say the important component of this, where it gets to the active follow-up for clinically important adverse events, occurs on the right-hand side of this slide, where if an individual checks one of those three boxes there, you miss work, you're unable to do your normal daily activities, or you sought care from a doctor or other healthcare professional, check any one of those boxes being checked would constitute a clinically important adverse event, and then trigger that cascade of action where we send the contact information to the call center. The call center reaches out and takes a VAERS report. So you can see a clinically important adverse event is defined here as fairly general. The VAERS report will be specific, and it'll go through the normal VAERS process where we take information on the symptoms, the signs and symptoms. That will go through a meta-recoding process, and so we'll get information specifically on what kind of adverse event it was. Next slide. Next slide, please. So CDC has validated the basic text messaging collection methods for vaccine safety monitoring. Smartphone-based monitoring of early vaccine recipients will allow estimation of rates of local and systemic reactogenicity and rates of clinically important adverse events following immunization. And this type of monitoring will allow comparison of observed rates of adverse events with background rates in the population and with known rates following other types of vaccination, such as influenza. Next slide. So now I want to describe enhanced VAERS reporting using the National Healthcare Safety Network sites, COVID-19 vaccine safety surveillance, and facilitated VAERS reporting from healthcare workers and long-term care facility residents will occur through NHSN, which is a CDC surveillance system that its principal purpose is to monitor healthcare acquired infections. And this is a screenshot of the NHSN program here. Next slide. So NHSN sites will track weekly vaccine doses administered by dose number, dose 1 or dose 2, in healthcare workers and in long-term care facility residents. So this is denominator data. And the NHSN sites are well positioned to identify adverse events among COVID-19 vaccine recipients at their sites. This is the numerator data. So VAERS staff will match reports in VAERS to NHSN sites using facility address information, which basically means we can identify reports originating from NHSN sites by running two lists, the VAERS report with the NHSN facility site addresses. So we'll be able to get that numerator information specific to the NHSN sites, and then we have denominator information because we're getting that as part of some of their routine reporting requirements. And this will allow for calculation of crude overall reporting rates and adverse event specific reporting rates.
Great. Next slide. So I'm going to start with the safety monitoring timeline and covered populations in early vaccination. Next slide. So I'm going to basically build out a timeline here where I'm going to show our safety monitoring systems and when they come online. And when I start with the very early monitoring systems, they are ordered from top to bottom. They will all be active and functional when vaccine becomes available. I've ordered them in the order which I think data may become available in them. And so I would like to start, next slide, by mentioning vSafe, which is a new vaccine safety monitoring system that CDC has stood up for COVID-19. It's an active surveillance program that uses smartphone-based tools to conduct check-ins, and we're doing primary data collection on adverse events that individuals might be experiencing after vaccination. And we also have the capability to do phone follow-up and take adverse event reports if these individuals report a significant health event. This should start, this requires registration, but is going to start collecting data immediately on day 0 and collects data out to 12 months after the second dose of vaccination. Next slide. So I want to also mention our passive surveillance or spontaneous reporting system, which is the Vaccine Adverse Event Reporting System, which is co-managed by CDC and FDA. And VAERS will be available immediately when vaccine becomes available, and we've ramped up to anticipate additional reporting for COVID. What you see on top there are some systems that report or feed into VAERS. DoD and VA actually run their own spontaneous reporting systems in their healthcare systems, and they report into VAERS. And we've also done work with the National Healthcare Safety Network to increase awareness of adverse events and to encourage reporting to VAERS. Next slide. And the Clinical Immunization Safety Assessment Project at CDC, which is a collaboration between 7 medical research centers and CDC, conducts individual case consults. They're staffed up and ready to go to start doing case consults, and that often gives us an early look at unusual or unexpected adverse events which come to the attention of healthcare providers which are requesting assistance with the review. Next slide. So shortly after vaccine becomes available, if the projections that we anticipate materialize, we'll begin to accumulate substantial data in our large link database monitoring systems, many of which we conduct near real-time sequential monitoring or rapid cycle analysis. This includes the CDC's Vaccine Safety Data Link, the FDA surveillance programs like their collaboration with CMS and BEST and PRISM, the VA Electronic Health Record and Data Warehouse, the Department of Defense Defense Medical Surveillance System, and then later on I'm going to describe this new initiative with Genesis. Next slide. This is just a table describing these systems in a little more detail to include the population and whether there is coverage for healthcare workers or long-term care facility residents. So VAERS, which is our system that monitors safety in the general population, and to include also NHSN acute care and long-term care facilities, will have coverage on healthcare workers and long-term care facility residents. For vSafe, all COVID-19 vaccine recipients will be eligible to participate in vSafe, provided they have a smartphone and can access the surveys. And we anticipate that a substantial number of healthcare workers will participate in vSafe. However, due to technical limitations and maybe even some physical limitations, there may be limited capture of long-term care facility residents in vSafe. Then we move on to these large link database systems, which at the top there, you see the vaccine safety data link that includes insured patients in the VSD sites. There are a substantial number of healthcare workers in these VSD sites. Some of these sites are large Kaiser programs. There is also a substantial number of adults 65 and older in VSD. The ability to identify nursing home residents is challenging in these sites. So we think there may be limited visibility on long-term care facility residents. For the FDA CMS collaboration, this is 90+% of older adults in the U.S., including 650,000 long-term care facility residents, which they can identify and monitor separately from the community dwelling older adults. There may be limited healthcare workers just due to the age demographics there, but definitely capture of long-term care facility residents. BEST and PRISM is similar patient populations to the VSD. The VA Electronic Health Record and Data Warehouse includes enrolled VA patients, so it's likely limited healthcare workers, but the VA does run their own nursing homes. It's a relatively small population, but these are captured as enrolled VA patients, and we will have information on them from the VA data sources. The Defense Medical Surveillance System primarily focuses on active duty military, and there's limited information on beneficiaries. So there will be substantial capture of healthcare workers and likely limited capture in long-term care facility residents. The Genesis Healthcare Data is a new collaboration. CDC is working with Brown University and NIH. The Genesis Healthcare has electronic health record information on long-term care facility residents, of which there are approximately 35,000 long-stay residents. They currently are not capturing information on healthcare workers, although there's some discussions on that, but definitely capturing information on long-stay residents in their EHR. Next slide. This is more of a reference slide showing our systems broken down by routine or established or traditional systems on the left side there, and then new systems on the right. And then on the top, systems are used for signal detection, and then on the bottom, systems used for signal assessment. You'll see there is overlap between signal detection and signal assessment. For example, we do rapid cycle analysis in VSD, and we also go in and assess signals in VSD as well.
Good morning or good afternoon. I'll be giving a COVID-19 vaccine safety update today. Next slide. So now I'm going to move into safety and pregnancy. Next slide. So this is the same slide I showed previously, but I'm highlighting the self-reported pregnancies to VSafe, of which there are just over 30,000. And the next couple slides I'm going to show you look at these 30,000 individuals and are looking at reactogenicity. So next slide, please. So this is looking at day one post-vaccination local reactions in pregnant and non-pregnant women aged 16 to 54 years. So on the top there, we basically are looking at Pfizer-BioNTech dose 1 and then Moderna dose 1. And in the blue bar, you have self-reported pregnant women, and in the orange bar, these are non-pregnant women. And I think the take-home from this is we're not really seeing any substantial differences in local reactions between self-reported pregnant women and non-pregnant women. In fact, there may be a little bit less reported local reactions in pregnant women compared to non-pregnant women, although those are kind of small numbers. And then you have some data for the Pfizer-BioNTech dose 2 down there, which looks actually pretty similar to dose 1. Next slide. So this is day one post-vaccination. This should actually be, systemic reactions. That's a typo on that slide there. First looking at, on the top there, Pfizer BioNTech dose 1 and Moderna dose 1. And again, when you're in pregnant, self-reported pregnant in blue and non-pregnant in orange. And when you're looking at these systemic symptoms, fatigue, headache, myalgia, chills, nausea, and fever, we're not seeing a safety problem with respect to these systemic symptoms in pregnant women compared to non-pregnant women. In fact, there may be a little bit higher self-reported systemic symptoms in non-pregnant women. Then if you look on the left-hand side and go from top to bottom, we have the Pfizer-BioNTech dose 1 compared to dose 2. And I mean, similar to what I showed you previously, dose 2 is there's substantially more systemic symptoms reported after dose 2. But when you look at the comparison between self-reported pregnant women and non-pregnant women, you're not seeing any concerning patterns there. Again, if anything, there's a little less systemic symptoms reported in pregnant women compared to non-pregnant women. Next slide. So moving on to the V-Safe Pregnancy Registry. So V-Safe participants who report pregnancy following COVID-19 vaccination are actively contacted to enroll in the pregnancy registry. Participants are contacted once per trimester, then after delivery, and when the infant is 3 months old. The outcomes of interest include miscarriage and stillbirth, pregnancy complications, maternal intensive care unit admission, adverse birth outcomes, neonatal death, infant hospitalization, and birth defects. Next slide. So as of February 19th, there is 1,815 pregnant women enrolled in the V-Safe Pregnancy Registry. I'll say that's well past 2,000 by now. In the enrolled population at this time, there had been 275 completed pregnancies, including 232 live births. Other outcomes included miscarriage, stillbirth, ectopical or tubal pregnancies. Next slide. So this table here shows V-Safe Pregnancy Registry outcomes of interest in COVID-19 vaccinated women with a comparison to background rates. So on the left-hand side of this table here, you see we have pregnancy outcomes, pregnancy complications, and then neonatal events. And in the first column to the right, we have background rates based on published literature, and then the rates we're seeing in the V-Safe Pregnancy Registry overall. I think the take-home here is when you compare the percentages in the V-Safe registrants compared to background rates, we're not seeing any concerning patterns with respect to the outcomes and events in the V-Safe Pregnancy Registry compared to what we would expect from background rates listed there in that middle column. Next slide. This is just a reference slide for where we got those background rates. Next slide. So moving on to VAERS data. These are the characteristics of COVID-19 vaccine pregnancy reports to VAERS through February 16th, of which there are 154. The median maternal age in these reports is 33, ranging from 16 to 51. Median gestational age is 13 weeks, ranging from 2 to 38. Just over half of these reports involved pregnancies during the first trimester, about a third during the second, and the remainder in the third. And you see the vaccines there below at the bottom. Next slide. So this is looking at the adverse events in pregnant women following COVID-19 vaccine. And I just want to take you to the bottom of this table first. You'll see that about 73%, so about 3/4 of these 154 reports involve non-pregnancy specific adverse events. So adverse events you would expect just in the general population, which typically are systemic and local reactions, as you see there. So of the 42 pregnancy or neonatal specific conditions, which is 27% of the total reports, Miscarriage was most commonly reported with 29 reports, and then you see small numbers of some of these other pregnancy or neonatal specific conditions. So just to put those 29 reports of miscarriage into perspective, the frequency of clinically recognized early pregnancy loss for women aged 20 to 30 years is estimated to be between 9 and 17%. At age 30, it's 20%. At age 40, it's 40%. And age 45, it's 80%. And this comes from an ACOG practice bulletin. So miscarriage is not an uncommon outcome of pregnancy. Next slide. So there are some other activities, CDC COVID-19 maternal vaccination safety activities ongoing. In the vaccine safety data link, there is a COVID-19 vaccination coverage project in pregnant women. There's a study on the risk of miscarriage and stillbirth following COVID-19 vaccination, and a safety and pregnancy study looking at acute adverse events, long-term safety assessment of acute adverse events, pregnancy complications, and birth outcomes, and infant follow-up for the first year of life. There is a prospective observational cohort study planned in the Clinical Immunization Safety Assessment Project, which is going to look at adverse pregnancy and birth outcomes, serious adverse events, local and systemic reactogenicity, and infant health outcomes for the first 3 months of life. Next slide. So just to sum up maternal vaccination safety, pregnant women were not specifically included in pre-authorization clinical trials of COVID-19 vaccines. So post-authorization safety monitoring and research are the primary ways to obtain safety data on COVID-19 vaccination during pregnancy. There have been substantial numbers of self-reported pregnant persons that have registered in VSafe. The reactogenicity profile and adverse events observed among pregnant women in VSafe did not indicate a safety problem. Most reports to VAERS among pregnant women involve non-pregnancy specific adverse events, mainly local and systemic reactions. Miscarriage was the most frequently reported pregnancy-specific adverse event to VAERS. The numbers are within the known background rates based on presumed COVID-19 vaccine doses administered to pregnant women. And by presumed, what I mean is we don't know how many pregnant women out there have been vaccinated, but we do know that there's been just over 30,000 self-reported pregnant women just in VSafe alone. So I think we can presume that there are tens of thousands of pregnant women that have been vaccinated. And based on the data we have right now, we don't see any evidence of a safety problem with respect to vaccination of pregnant women with COVID-19 vaccines. Next slide. So some closing thoughts. 75 million COVID-19 vaccine doses have been administered in the United States through the end of February. The reactogenicity profiles of messenger RNA vaccines and VSafe monitoring are consistent with what was observed in the clinical trials, and systemic and local reactions are most commonly reported to VAERS. Anaphylaxis following both vaccines has been reported to VAERS, though rarely, and there's no other safety signals for serious adverse events that have been detected in VAERS. There's no safety concerns that have been detected among the VSD rapid cycle analysis pre-specified outcomes as of February 13th. No unexpected pregnancy or infant outcomes have been observed related to COVID-19 vaccination during pregnancy. And safety monitoring in pregnant women is ongoing and planned in VSafe, VAERS, VSD, and CISA. Next slide. I'd like to acknowledge the contributions of investigators from the following organization, and that concludes my presentation. So I'll be providing a vaccine safety update with a focus on a couple areas, which I'll get into. So now I'm going to move on to myocarditis and pericarditis. Next slide. So the first part of this presentation will focus on VAERS data, which I just described the system. Next slide. And I want to mention that our clinical immunization safety assessment project participated in reviewing individual cases of myocarditis and pericarditis, and also provided expert feedback on the development of the CDC working case definitions for myocarditis and pericarditis. Next slide. So these are a table showing preliminary myocarditis and pericarditis reports to VAERS following mRNA COVID-19 vaccination by dose number. By preliminary, it means that these are reports that are identified through the VAERS database using MEDRA code searches, or ones that are pre-screened by the VAERS contractor and identified because they are suggestive of myocarditis or pericarditis and are brought to CDC's attention, or reports that we either become aware of because we're contacted by healthcare providers and we can help them submit a report, or they've already submitted a report and are contacting us, and we are able to go in and access that report rapidly. Some of these reports have been followed up on, reviewed, and adjudicated. Others, that follow-up review and adjudication process is ongoing. And this is after about 300 million mRNA doses administered. I think that the general pattern here is you can see that there are more reports after dose 2 than after dose 1. There are a small number, relatively small number of reports with an unknown dose. And for moving forward, we're going to focus on reports where we have dose number because that factors into our analysis. Next slide. So these are the characteristics of these reports following dose 1 and dose 2. And I think some of the main points on this in this table are that the median age of patients experiencing myocarditis or pericarditis following mRNA COVID-19 vaccination is younger for dose 2, 24 years compared to 30 years. The median time to symptom onset after dose 2 is a little bit shorter, 3 days compared to 4 days. And for dose 2, there is a stronger male to female preponderance of reports. It's 79% to 20% after dose 2 compared to 66% to 33% after dose 1. Next slide. So this is a figure looking at vaccination by age and looking at reports by age and dose number. And I think the take home here is you can see the dose 2 reports are in red, the dose 1 reports are in blue. And you can see that most of these, and it's truncated after 50 because after about the mid-20s, it really flattens out. That most of these reports are occurring in individuals in their late teens and early 20s. And this is really more pronounced for the dose 2 reports compared to dose 1 reports. But for both, they tend to cluster in the late teens, early 20s. Next slide. These are looking at reports by dose number and time to symptom onset. Again, dose 2 in red, dose 1 in blue. And we've truncated this after 29 days. But you can see after about 6 or 7 days, these really do flatten out. And we have a clear pattern of clustering, and you'll see this later in the VSD data as well, a clear pattern of symptom onset clustering in these several days after vaccination, with most of these occurring within a week of vaccination. Next slide. So this graph here is limited to reports in individuals less than 29 years of age and less. Much of our analysis focuses on these younger age groups because this is where we're seeing most of the reports, especially the recent reports. So this is limited to the 484 preliminary myocarditis and pericarditis reports in individuals 29 years and younger. Chest pain is the most common presenting symptom. Dyspnea is also common, though less common than chest pain. And as far as diagnostics, ST and T wave changes on ECG and elevated troponins commonly documented in the reports, and then also a substantial number documenting abnormal echocardiography or imaging, which is often MRI, noted in the reports. Next slide. So of these 484 reports in persons less than 29, 323 have met the CDC working case definition of myocarditis or pericarditis or both, so myopericarditis, and 148 are under review. I want to just mention or clarify that we currently this is a combined category, so we're combining both of these conditions and these conditions when they occur together into a single outcome. Of these 323 reports that met case definition, 309 were hospitalized. 295 at the time of this analysis were discharged, and 218 of these 295, almost 80%, are known to have recovered from symptoms at the time of the report. Relatively small number were not hospitalized. These were seen in the emergency department, urgent care, or as outpatients. Next slide. This is a reference slide showing the case definition for myocarditis. Next slide. This is another reference slide showing the definition for pericarditis. Next slide. So I'm going to move into a series of tables here. I'm actually, in the interest of time, gonna forward to the final table, but I'll just kind of orient you to what these tables are. These are preliminary myocarditis and pericarditis reports to VAERS following a specific dose of an mRNA vaccination and an observed versus expected analysis looking at a particular risk window. Right here, we're looking at dose 1 and a 21-day risk window. And from the previous information I presented, we have evidence of a dose effect, most reports occurring after dose 2, and clustering within a few days, symptom onset within a few days of vaccination, so within a 7-day risk window. And I'm just going to forward to the last slide because I think that is the most informative one. Next slide. Next slide. Next slide. So these are reports to VAERS, myocarditis, pericarditis reports to VAERS following dose 2 with an observed versus expected analysis using a 7-day risk window. It's the age groups are there on the left side, and then you have doses administered, and the observed cases are the actual reports to VAERS after dose 2, where symptom onset was in the 7-day risk window. The expected are expected counts based on estimates that we generated from incidence rates in published literature. That was a FDA CDC literature review with an adjustment for male and female percentages. And I think the take-home message here is that we're observing this in younger age groups, mainly in people in the teens and early 20s, and observing it more in males compared to females. And the difference in the observed versus the expected appears to be greater, generally speaking, in males versus females. And this effect largely kind of disappears once you get into these older age groups, so individuals 50 and over. Next slide. So this is a busy slide, but these are preliminary myocarditis and pericarditis crude reporting rates to VAERS following mRNA COVID-19 vaccination with no restrictions on post-vaccination observation time. So this is basically the number of reports in these specific age groups and by male, female, and by dose, divided by the number of doses administered in the strata times 1 million. It gives you the crude reporting rate per million doses. And the key features of this table is that you see at all ages until you get to these older age groups again, the reporting rate in males is greater than the reporting rate in females. And for both sexes, the reporting rate after dose 2 is greater than after dose 1. So this really kind of confirms a lot of the information that I presented up to this point, kind of looking at this at a high level with straight up reporting rates. Next slide. Now I want to move into data from our vaccine safety data link system. Just to remind you, this is our population-based large link data system that we use for active surveillance and research. It's an EHR-based system that includes 9 participating integrated healthcare organizations with data on over 12 million persons per year. Next slide. In VSD, we have complete or near complete information from electronic health records to include immunizations, outpatient, inpatient, ED visits, procedures, birth and death certificate information, and demographics, all linked by unique study IDs. And we have rapid access to charts and electronic health records to go in and review cases. Next slide. The analysis we do in VSD is called rapid cycle analysis. It's near real-time sequential monitoring as data become available. It monitors a limited set of pre-specified vaccine safety outcomes. It is a public health surveillance activity, which is not the same as an epidemiologic study. It is designed to detect statistically significant associations and statistical signals, which do not necessarily indicate a safety problem. When you detect statistical signals, they require further evaluation. Next slide. These are the doses administered through June 12th in VSD, about 4.5 total doses for Moderna and about 5.8 million total doses for Pfizer. Next slide. This is that data broken down by age group. And the take-home message here is there's substantial doses administered in the 18 to 49-year-old age group, but at this point, still fairly limited doses administered in the 12 to 59-year-old age group and the 16 to 17-year-old age group. Next slide. So this is VSD rapid cycle analysis, overall analysis for outcome events in the 21-day risk interval after either dose of any mRNA vaccine compared with outcome events in vaccinated comparators. So this is the vaccinated concurrent comparator analysis. As you can see in the overall sequential monitoring that we're doing for the pre-specified outcomes listed, we have observed no signals to date, and specifically for myocarditis, pericarditis, the adjusted rate ratio is just over 1 and has not statistically signaled yet. Next slide. Given what we've observed in VAERS, we went in and did an age stratified analysis. So this is really an activity done outside of the sequential monitoring. So outside of the surveillance we're doing, we went in and did an age stratified analysis. And these are actually chart-confirmed events in the 12 to 39-year-old age group in the 21-day risk interval. As we accumulate more data, we can probably slice that age group a little finer. This is really the meaningful data that we had available at this point. And you can see for any mRNA vaccine, any mRNA vaccination for both doses combined, the adjusted rate ratio is 3.5 and is statistically significant. The confidence interval is 1.1 to 15. It's elevated for dose 1, but not statistically significant, and also elevated for dose 2 at 3.6 and is statistically significant. For the Pfizer-BioNTech vaccine, the adjusted rate ratios are slightly elevated, but none of them reach statistical significance. And then for the Moderna vaccine, the reason that the adjusted rate ratios are not estimable is because at this point we don't have any events in the control interval, so we cannot estimate an adjusted rate ratio. But these 95% confidence intervals, the lower bound for both doses, and for the dose 2 is greater than 1. And it's likely these Moderna findings are driving the overall analysis for any mRNA vaccine. Next slide. So this is the same analysis, but looking in the 7-day risk window. Again, we're narrowing the risk window because we have evidence to suggest that that the symptom onset occurs within that first week. So if you look here again, similar findings for the combined analysis. The adjusted rate ratio for both doses, any vaccine, is 10 and statistically significant. It's elevated for dose 1, but has not reached statistical significance. And then for dose 2, again, adjusted rate ratio 10.8 and statistically significant. For the Pfizer vaccine now, for dose 2, the adjusted rate ratio is elevated and statistically significant, and you see similar findings there for the Moderna vaccine with no events in the control window to date. Next slide. So these are chart-confirmed myocarditis and pericarditis cases in VSD by day of symptom onset since the most recent vaccination in 12 to 39-year-olds, and running a SAT scan analysis here. And you see the most likely clusters are occurring on days 0 to 5, 0 to 3, and 0 to 6. So we have clear evidence here of onset for these vaccinated cases within the first week post-vaccination. I'll mention that this analysis includes cases on day 0. For some of the other previous statistical testing, they did not include day 0. Next slide. So these are straight up rates, chart-confirmed rates in VSD in the 21-day risk interval, so in the 21 days following vaccination in 12 to 39-year-olds. And I think that there's two important features of this table. First of all, we're seeing a dose effect. So the rates, and again, this is not an attributable risk. These are just straight up rates of myocarditis and pericarditis following vaccination in the 21 days. You can see that the rates are higher for both vaccines after dose 2 and in the combined analysis. However, this is still a rare event. For both vaccines combined, 12.6 cases per million doses administered, and the highest rate is actually just under 20 per million doses administered. Next slide. This is showing the care and status of chart-confirmed myocarditis cases, and this includes cases with onset on the day of vaccination, so 0, so it's 29 cases. You can see most of these cases are hospitalized, either inpatient or in the case of 2 of these in the ICU. The median length of hospital stay is 1 day with a range of 0 to 13. All were discharged home at the time of chart review, and a follow-up visit was noted in 27 of the 29 cases in VSD in the 21 days following vaccination. As far as a qualitative summary, nearly all follow-up visit notes indicated resolution of symptoms at the time of follow-up, and of those who had follow-up ECG or echo or other lab testing, most had returned to normal or baseline. As far as treatment plan, most follow-up visit notes indicate tapering of some medications, and the notes indicated maintenance of colchicine and activity limitations for 3 to 6 months. Next slide. So this slide looks at myocarditis and pericarditis rates based on ICD-10 coded cases. So these are all cases, not just chart-confirmed cases. And again, in the 21-day risk interval, ages 12 to 39. And I just want to focus on actually 2 findings here. This focus on the overall analysis. You see that so for females after dose 2, the rate in the 21 days after vaccination is 4.7 cases per million doses administered. Again, these are ICD coded cases. And then for males, 32 per million. So again, you're seeing a dose effect here with dose 2 rates higher than dose 1, but still this is a rare condition, 4.7 per million and 32 per million. So remember those 2 numbers, 4.7 and 32. Can you go to the next slide? This is the same slide I showed previously. These are VAERS reporting rates. Now, if you look at the female The female reporting rates where I've circled. In the younger age groups, it's as high as 9, and then we get to 30 to 39, 1.8. So if you smooth that out a little bit and think about the VSD rates, 4.7, it's within this range that we're seeing in VAERS. And then for males, it was 32. Again, it goes from about 66.7 down to 10. Again, if you smooth that out with the total age groups, it's probably within that range, a reasonable estimate. So we think these are pretty comparable rates when you look at automated cases in VAERS or ICD-10 coded cases in VSD, which to us is indirect evidence that the capture of these cases in VAERS is probably pretty good. So the reporting efficiency of post-vaccination myocarditis and pericarditis to VAERS is probably pretty high, and we're getting good capture of these cases by reporting primarily by healthcare providers. Next slide. Next slide. So in summary, the initial safety findings of the Pfizer-BioNTech COVID-19 vaccination of told to 15-year-olds from VSafe and VAERS are consistent with the results from pre-authorization clinical trials. Analysis of VAERS preliminary reports is in progress, including follow-up, applying the CDC working case definition and adjudicating cases. The preliminary findings suggest that the median age of reported patients is younger for reports after dose 2 versus dose 1. The symptom onset clusters within a week following vaccination. There's a predominance of male patients in younger age groups, especially after dose 2. The observed reports exceed expected cases, especially after dose 2 in younger age groups. The early VSD data in the 12 to 39-year-olds also suggests that more cases, there are more cases after mRNA COVID-19 vaccination with dose 2 versus dose 1. The rate of 12.6 million there's a rate of 12.6 million cases following second dose mRNA vaccination in the 21 days following vaccination, and these rates appear higher in males than females. And there's clustering within the week following vaccination, most likely within 0 to 5 days. Reassuringly, the available outcome data indicate that patients generally recover from symptoms and do well. Next slide. So as far as next steps, we'll continue monitoring in VAERS. We're going to follow up to obtain medical records, do case reviews, apply the working case definition, and adjudicate reports. We have a surveillance review focusing on myocarditis and myopericarditis in progress. We'll continue monitoring and assessment in VSD to quantify the risk and characterize the clinical features. And we plan to conduct follow-up on vaccine-associated cases to assess longer-term outcomes, those at 3 to 6 months.